My name is Tebohole Pile from Botswana. I am a PhD candidate in the Faculty of Land and Food Systems. I'm also one of the co-chairs of the Lu Institute Network for Africa, which is also called LINA, the host of this webinar series themed COVID-19 and Africa. The Lu Institute Network for Africa is a graduate student-led research-based network at the UBC School of Public Policy and Global Affairs. We exist to bring together stakeholders within research and policy to address governance and development issues in Africa. I would like to let you know that there is a Q&A at the bottom, so you'll see that icon. Please upvote the questions. And I would also like to inform you that the session will be recorded and will be later published on the LINA website. We are grateful to have you today. Thank you.
Thank you so much, Tabby Day, and welcome to all of you. We've got over 100 people here. Welcome to all of you, and especially to our esteemed guests from the African continent. We aim to have an Afrocentric conversation today, showing the strengths and the resilience of African health systems in the face of COVID-19. And so before we begin with our speakers from the African continent, we've got a video from our president, Dr. Santa Ono.
Hello, I'm Santa Ono, President and Vice Chancellor of UBC. I'd like to welcome you to this webinar series on COVID-19 in Africa. I'd also like to thank the graduate students who have organized this important event. The series will explore and share experiences on the impact of COVID-19 in Africa. For example, public health, food security, and education. It will highlight Africa's unique response to the pandemic, both the country-specific efforts and the collective continental response. UBC believes in Africa's potential and that of its people, and is committed to supporting Africa and Africans at UBC and beyond. Today is a true testament to this, as you are gathered virtually for an event organized by African students to learn from world-renowned African experts. The sustainability of UBC is anchored on the principles of diversity and inclusion. We, therefore, recognize and acknowledge the significance of unique stories and experiences of the African people in education and global development. Universities can play an important role in providing solutions to problems such as the COVID-19 pandemic, which is why today's webinar is so important. Such global problems can only be solved by global cooperation, with researchers and others around the world collaborating across disciplines and across national borders. I wish you all the best in this webinar series.
Thank you so much to Professor Ono, the president of the University of British Columbia. And I am Farah Shroff, Dr. Farah Shroff, the moderator of this series. I am a public health researcher and educator. I was born in Kenya. I hold an honorary faculty appointment at a university in Kenya, and it really is my honor today to moderate this session. So without further ado, I would like to introduce our first speaker from Rwanda, Dr. Thierry Nyatanyi, who is a professor, and he is leading Rwanda's efforts in COVID-19. And I just want to say personally that it's really wonderful to have you here. I always invite Professor Hinda Rutan into my classes to talk about Rwanda and the amazing work that Rwanda is doing. So it's wonderful to have you here. Welcome, Dr. Thierry.
So I'll be presenting you Rwanda's response to COVID-19. My name is Thierry Nyatanyi. I'm a senior advisor to the Ministry of Health on COVID-19 response. I'll start by introducing to those of you who don't know much about Rwanda. It's usually called the land of a thousand hills, located in Central Africa, and with a population of 11 million inhabitants. And most important to note on this slide is that 50% of the population is under 18 years. So as you all know, COVID, especially most of the people who are infected are actually who become severely ill are elderly. So our population is very young, 50%. And also to note is that Rwanda is among the countries that was most densely populated. So with more than 483 people per square kilometer. And also, most important to note about the slide is that the country is landlocked. So I'll be presenting you some of the cases we've had. Most of the cases are imported cases. So because travel and trade, especially with importations, most importations have to go through one country or two countries because the country is landlocked. So briefly, this is the overview of my presentation. I'll be talking about the epidemiological situation, the COVID response structure, lab capacity, surveillance, and lessons learned in health systems resilience. So first to note is that prior to the first case, so Rwanda confirmed the first case on 14th March. And prior to that, we had done tremendous efforts in terms of preparedness. We had procured lab testing kits, we had trained, we had issued out public notices, and also we had created an official COVID-19 task force. And also I would like to say that most of these measures were building on the Ebola preparedness, given the fact that last year there was an outbreak of Ebola in Eastern DRC, which is close to Rwanda. So we had to put in place preparedness measures that currently actually are helping us also to respond to COVID-19. So again, prior to the identification of the first case, large gatherings, including churches, were prohibited. And then immediately after confirmation of the first case, schools were closed. And a week later, the airports were closed. And the country went into a national lockdown on 21st of March. That's just 7 days after the confirmation of the first case. We also instituted policies regarding masks, wearing masks, where social distancing is difficult. And as I said, we started identifying cases of truck drivers, and we put in place testing capacities at the borders. So all truck drivers coming in Rwanda currently are supposed to be tested before proceeding. And later on, the lockdown was also again extended. But businesses and essential services were opened. But a curfew was also imposed starting from 5 a.m. to 8 p.m. And movements within provinces were also allowed. Then quickly moving forward is that on 2nd June, we had a widespread community transmission in one of the districts in Western Province. So currently, that district is under lockdown. No one moves outside and no one enters. Though we've started seeing that cases are now decreasing, so probably in the next coming days, we'll reassess the epidemiological situation to see if we can reopen the district. Then quickly, on 16th June, we reopened charter flights for tourism, but again, all borders are closed, especially for trucks bringing in essential goods. And also the airports are closed, so the airspace is closed, and we'll be opening the airspace on 1st August. And we also had a cluster of cases in Kigali, which is the capital city. So we currently have 6 villages under lockdown. But in the past few weeks, we've had a lot of cases in detention facilities. So most of the cases that we've identified in the past 2 weeks are cases that were confirmed in detention facilities. So as you can see, again, coming back to being a country that's landlocked, the yellow bars represent the local transmission, like local cases, but also the blue bars represent the imported cases, which again represent a significant number. From the beginning of the outbreak until today, we keep on seeing imported cases because we can't close the country to trade. So briefly, this is the same slide with the number of cases, but this time demonstrating the recoveries. So far, we have a case fatality rate per million population of 0.3%, and almost all, 98% of our cases recover with symptomatic and mild symptoms. only requiring isolation and supportive management. So compared to the global case fatality rate, actually, which stands at 4%, and in general, in Africa, it's around 2%. So briefly, these are AP indicators that we analyze continuously, showing in the past 2 weeks, comparing the past 2 weeks and in the past 1 month. So again, we have, So we have, again, a lot of imported cases that represent 29% of the total number of cases. And then we're also conducting a lot of testing. And the current positivity rate is of 0.74. So quickly, the demographics, which is also very important. More males are affected compared to females, which highlights that, of course, most of the cases we've been seeing are cases that we identify in truck drivers and also in detention centers. But also looking at the age categories, 92% of all cases are below 50 years. So probably which highlights why the case fatality rate is still low. Quickly, this is the estimate time of varying the RT. Currently, our RT stands at 0.99, ranging between 0.9 and 1.1. So there is a likelihood that the outbreak can easily escalate if at all we go beyond 1. So we are working hard to make sure that actually it stays below 1 so that we can keep on continuing it. Quickly, the command structure and the response structure. This is the national coordination structure. And the Prime Minister's office, because COVID-19 response requires a multidisciplinary collaboration. Not only we are working as a Ministry of Health, but we also have all sectors, other sectors actually that are involved. Most importantly, local government, security organs, ministries of finance. And the technical component is overseen by the Ministry of Health, which actually is responsible to manage the COVID-19 task force coordination. And so we have also technical teams, epidemiology, administration, and communications. So moving forward, we're also envisaging to decentralize COVID-19 response, given the fact that right now we're still trying to contain the outbreak, but as a mitigation strategy, we're trying to decentralize COVID-19 response, as well as decentralizing care and treatment, and also task shifting, so that in any case, we can be able to manage cases in health facilities around the country. Because right now, we have treatment centers that are specific for COVID-19 in order not to disrupt healthcare services. But moving forward, we're envisaging to see how this can be decentralized in our health facilities. So our lab capacity, this is the algorithm. So we use 2 tests for us to confirm the positive case. They're supposed to be tested using the 2 RT-PCR tests, the 2019 nCoV RNA, and also another one that uses light mix and RT-PCR from Germany. And we usually target 2 genes, the E gene and the RGRP gene. So once someone is positive on both those genes, they are confirmed positive. And if there is a discordance, then it's a presumptive case, and we have to retest it. So currently our capacity, we can test more than 2,500 samples a day. And our turnaround time is between 48 and 72 hours. And most importantly, for large samples, we do pool testing, and the pool sizes are of 20 samples. So which is very important given the fact that we have limited resources. So we're trying to maximize lab testing using this strategy. And we've also put in place satellite laboratories that will serve provinces that can have a capacity of testing more than 100 samples per day. So briefly, this is a lab diagnostic testing graph showing the percent positive, which currently stands at 0.7. And most important also to note is that for every case that's confirmed, we are testing 142 people, so which is really high. And but however much it's high, we're trying to see how we can increase that capacity. So we're also implementing other measures, most importantly surveillance strategies. So we're conducting mass screening for high-risk occupations, such as markets, shops, hotels, banks, and also we've instituted drive-throughs and walk-throughs, where people just drive in and then they get tested, and then they go on without getting out of the car, or motorcycles or walk-throughs where people just walk in and then they get tested. We're also doing active surveillance, of course, for contact tracing, and also we have instituted sentinel surveillance, whereby in health facilities, everyone presenting with severe acute respiratory infections is tested, and also we get some samples for people presenting with influenza-like illness, just to make sure that if at all we have people with COVID-19 that are in the community, if they're seeking healthcare, so as not to miss them out. So other measures, non-pharmaceutical public health measures, very important, and this is where we've had collaboration with other government institutions, especially local government, transport. So social distancing measures in public places, such as bus parks, and also hand washing in terms of really making sure that we prevent the spread of COVID-19 in public places. And also the face masks, again, with law enforcement agencies, we've been able to really enforce some of these measures, because right now you can't walk for more than 50 meters without a face mask before you're stopped by a policeman or any other responsible citizen. So lastly, lessons from COVID-19 and the health system resilience is that Rwanda has really improved. Probably most of you know that in 1994 we had a genocide, but since then the country has rebuilt itself, and we've had significant improvements in the healthcare system, where we've managed to double the life expectancy. We've cut infant mortality by 75%. We've reduced maternal mortality by more than 80%. And also we increased childbirth at medical centers to 91%. So building on this health system, we believe that actually, as we plan to decentralize COVID-19 management and coordination and response, we'll build on some of these pillars. And actually right now we've started looking at some of the health system strengthening pillars, including leadership and governance. We've used this approach actually to build community trust, especially during the lockdown period, and also for enforcing non-pharmaceutical public health measures. But also leadership has also played a big role in all aspects of COVID-19 response, including multi-institutional collaboration and coordination. And also in terms of access to essential medicine and financing. So the government has committed to provide free services for COVID-19 testing, quarantine, and treatment. So for all cases that are in treatment facilities, in treatment centers, treatment is free of charge. Quarantine is also free of charge. The government pays all those expenses, and also COVID-19 testing is free of charge. So there's no fee attached to all these approaches. We're also building on health information systems, especially in terms of data management, coming up with innovations that can be applied in all aspects of COVID-19 response, which includes case identification, testing, contact tracing and case management. So immediate and long-term challenges, of course, we had a huge economic impact. So most of the economic activities were affected. We still have issues in terms of cross-border travel and trade, as we continue to see clusters of cases in truck drivers. Supply chains, especially in terms of procurement of medicines and lab reagents, so it's taking too long. And we still have challenges around procuring some of these essential medicines as quickly as we want. And also continuity of healthcare services as prior to COVID-19. Of course, as we put in place triage systems, we are seeing a lot of panic and anxiety. If at all we have a suspect case in any of the health facilities, then it's still a challenge in terms of actually it can disrupt, routine healthcare delivery. And we also have a challenge in terms of lack of effective rapid diagnostic tests. So as of now, we do not have antibody or antigen-based tests that we can use. And actually, if we had these ones, then it would be much more easier to quickly identify cases and isolate them and contain the outbreak. Lastly, the global recession, which we believe will have an impact on our service industry and tourism, which is one of the main revenue-generating industry. With that said, I thank you so much.
Thank you so much, Dr. Thierry. That was a wonderful, wonderful overview of the incredible response that Rwanda is having to COVID-19. The world knows a little bit about these innovations that you talked about, the pooled testing. I don't know how many other countries are doing that, but the fact that Rwanda was able to close down just 7 days after the first case, March 21st, that's really incredible. And the free testing, the free quarantining, all the measures that you're taking show once again that Rwanda is doing a remarkable job and showing great innovations and resilience in the face of this. Thank you very, very, very much. We look forward to talking with you more about that in the question and answer period. Thank you. Thank you. Merci mille fois. C'était vraiment, vraiment apprécié. And now next we're going to move moving now from the eastern part of the continent down to the very tip of the mother continent to South Africa, where we're going to hear from Dr. Slim Abdul Karim Lamoka, and he is leading South Africa's efforts in this regard, and he's also a professor at Columbia University. Welcome, Dr. Slim. Oh, Dr.
Thank you very much. It's a great pleasure to be with you here. I'm going to put up my slides while I speak to you. I'm just very pleased and honored to have this opportunity to share with you very briefly a perspective on the epidemic in South Africa. I was very impressed with the efforts in Rwanda, and it's a great pleasure to see what's being done there. So I'll just briefly touch on the way in which the epidemic has been unfolding in South Africa. So we had our first case on the 5th of March, and initially, for the first 3 weeks, our epidemic was growing rapidly. We had a doubling time of about 2 days. Roughly, if you look at how we were comparing at that time, we were comparing pretty well with the UK, which has a similar population to South Africa. So we were on the same epidemic trajectory as the UK at that time. About 3 weeks into the epidemic, the government instituted a lockdown, and that lockdown was over 5 weeks. It was in one of 5 levels, and this was the highest level, the strictest level, level 5. And with the institution of the lockdown, the doubling time of the epidemic slowed quite dramatically, from doubling every 2 days to doubling every 15 days. As the lockdown has been eased, when we went to level 4, it was doubling at about 12 days, and under level 3, it's doubling at about 14 days. Actually, if you add in the last few days, it's now doubling at around 11 days. So the epidemic initially was growing rapidly, was slowed, and now it's starting to pick up steam. And we are now in a situation where we are in the midst of the surge. And that's evident when you look across the different provinces. The first province where the epidemic grew most rapidly and early was the Western Cape, followed by the Eastern Cape, and then the big metropolis of Johannesburg in Gauteng province, where the epidemic is growing very rapidly. We have about 6,000 or so cases every day in Johannesburg, and where it's still very early in KwaZulu-Natal, the province where I live. So the epidemic in South Africa is in varying stages by the different provinces. And so we are seeing peaks in the different provinces at different times. That has a slight advantage in that it evens out some of the demand on resources such as oxygen supply and so on. The primary goal of the South African response was flattening the curve, and the response comprised 8 stages that were overlapping each other. So the first stage was about preparation, and that was really about establishing testing capacity. It was about education, putting through materials, instituting checks in the port entries and the airports and the shipping yards and so on. And then we went, after we had our first case and the declaration of state of disaster about 10 days after the first case, and the state of disaster led to the prohibition of gatherings, the closing down of international travel, and so on. And then we went into a very much a primary prevention mode. And that prevention mode was about taking quite substantial steps to prevent interaction and to reduce spread. And then on the 27th of March, we started the national lockdown, which was about 12 days after the state of disaster was enacted. And we then went into the stage 3, which was this very strict lockdown, and then we've now been steadily easing the lockdown over time. And we also knew, and we had to start planning for the other steps in the response. And so very early on, we initiated active case finding. So we mobilized about 28,000 field workers who were going house to house to try and find individuals who had symptoms and to test them. We were concerned that if we didn't do that, we would end up with a situation where we would miss a whole lot of cases and the epidemic would grow quite rapidly. And before we know it, we would be sitting with the kind of situation that was evident in the UK. Our active case finding efforts are coming to an end, and we have been focusing on hotspots over the last month and a half. And hotspots are really where we've been seeing super spreading events, and we've been seeing cases increasing in clusters. And throughout all of this has been the preparation of the medical response and the medical care that's required. We have been building field hospitals in all of the different major centers. We've been planning the beds and staffing, the oxygen requirements, securing ventilators and so on. And at the same time, we've also been preparing for what we were expecting as an increase in deaths and bereavement. And finally, we've also been putting in place the steps to maintain vigilance. Once we can reach a situation where we've got some measure of sporadic cases only, we'll then have to institute vigilance to be monitoring for the second wave. So the 8 stages are what we put in place right at the beginning, and we started preparing all of these, and as you can see, they overlap quite a bit. Just touch on testing. South Africa has very substantial capacity to test using PCR platforms. We can actually do well over 100,000 tests per day because all of these platforms were actually built for our HIV and our TB diagnostic tests. And so the Gene Expert, you will find Gene Expert in most clinics in South Africa because we rolled it out quite a while ago for TB testing. And of course, high throughput laboratory-based PCR platforms are available in almost every lab because they are used for HIV viral loads. And so the testing platforms have never been an issue for us. And we have, as I said, quite substantial capacity. Our problem is we can't get hold of enough kits. And so that has been one of our major challenges. It's not a money issue. We've placed substantial orders with the suppliers, but we're trying to buy the same kits as everybody else is buying. And so we can only really secure somewhere in the region of between 30 and 40,000 tests per day. And that's about what we're doing right now, about 40,000 tests per day. So if you look at the average number of tests that we've done per week, we started off with doing about 120 tests per day in the first week. And in the last week, we were up to, well, now we're up to actually closer to 50,000 tests per day. And the tests are split roughly between the public and private sectors. They're split close to half and half between the two. And so this challenge of trying to get hold of enough kits has been a problem for us. And it's led to backlogs in the laboratories. And we've had longer turnaround times as a result. And that has led to compromising clinical care to some extent because now we're waiting for results and patients we don't know what their diagnosis is. And it's also led to challenges in prevention because we are tracing contacts too late because we get the results in a delayed manner. And we've had to prioritize our testing. Our testing now focuses principally on hospital patients, on healthcare workers, and on outbreaks. In the very traditional way in which we've seen the epidemic unfold in many of the countries like Australia and New Zealand and so on, that they go through these 4 stages, but these are the 4 stages described, which is you get the epidemic where the virus is spreading and you attempt to flatten the curve. And you do that successfully and you get to a point of some level of containment where you've just got very low and sporadic transmission. And then you start lifting your restrictions with your mitigation measures where you coexist with the virus. And you're trying to do that until such time that you can get a vaccine or a cure. So that's the overall strategy and approach that has been adopted. In South Africa, we've had to do things slightly differently because we are one of the many countries right now where we are easing restrictions while cases are rising. So we've had the epidemic, and we're still in the midst of the epidemic where the virus is spreading and spreading quite rapidly. We're still trying to flatten the curve, but because the lockdown is really not sustainable from an economic point of view, people need to go to work and earn their money, and we have very large numbers of people in the informal sector and in their own businesses. And so you have this challenge that we have to find a way to coexist with the virus while the epidemic is continuing to spread, because we have not been able to achieve containment. So our plan is to try and balance between the needs of trying to reduce transmission with the needs to try and ease restrictions so that the economy can get some momentum, and hope that through all of this balancing act, we can at some stage get to containment and then hope for a vaccine down the line. And so we've really changed the way we're looking at things, in that we're really seeing it as, right now we're planning for a marathon and we're not planning for a sprint. when we initially started, we were sort of thinking short term, but now we're thinking about the long term, and we're planning as if we'll be living with this viral threat, well beyond the end of next year. And we're not alone in this unfortunate situation where we're having to lift restrictions while cases are increasing. India, Russia, Pakistan are among the others that are in exactly the same situation. And so this creates multiple contradictions and paradoxes in that I call the stage, it's damned if you do and damned if you don't. Because if you say to people, okay, you can go back to work, and the cases are increasing, and then they get small outbreaks and they get cases among the staff, and they say, well, why do you make us go back to work? So if you open schools and you have the same challenges, half the people say, what on earth are you doing opening schools? The other half says, oh, the kids have to go to schools because we need to go to work. So you've got, no matter what you do, you're in this very contradictory stage of the response because you still have cases that are rising, but you at the same time are easing your restrictions. And so now our main strategy is about reducing outbreaks, the super spreading events, and about mitigation with prevention measures. And the way in which we sort of seeing this change occur is really that, initially when we dealt with this epidemic, we couldn't use our traditional public health model, which is how is the virus spread? What are the prevention strategies? We would design a program for it. We test it, pilot test it, adjust it, consult people on it, and then we'd implement it with early adopters and wait for diffusion. If we did that, the epidemic would have long passed us. So we had to take drastic action initially through the lockdown, and that created anxiety. People were concerned, people were scared. What is this virus? Why are we, all having to sit at home, and so on. But now we're asking people to actually develop agency, to use their own power to act, to protect themselves. And so the whole idea now is to move from anxiety to agency and to action. And to do that, we're asking people to control their own risk and to take up the prevention measures of social distancing and mask wearing and so on. And we're hoping that through enough individuals being motivated and taking up these prevention measures, that we will motivate and lead to collective action. Because South Africa is built on the philosophy of Ubuntu, which basically means I am because you are. So I am safe because you are safe. And where each person recognizes that when they put themselves at risk, they're not just putting themselves at risk, they're putting their families at risk, they're putting their work colleagues at risk, the travelers at risk, their communities, their neighbors. And so this kind of collective action is our emphasis right now, is to get collective action to try and slow the course of this epidemic. And I believe that because of South Africa's strong sense of interdependence, we fundamentally believe we are interdependent on each other. We are built on that. We think that that gives us an opportunity to really let that come to the fore so that we would be able to respond to this epidemic through our collective action. Thank you.
Thank you very, very much, Dr. Saleem. That was a very, very good. You talked about having a sprint, which you thought, at the beginning, you thought that COVID was going to be a sprint, but you gave us a good sprint through South Africa's amazing program that's using active case finding with people going door to door. This again is really innovative. The capacity of South Africa to test 100,000 people per day is amazing. It shows that the country has really learned from its experiences with HIV, TB, all of the things that you had to deal with in the past. You're now mobilizing the country to work on that infrastructure. And the easing of the restrictions that you talked about right now, even though the cases are rising, many countries are going through exactly this kind of a contradiction, this damned if you do and damned if you don't, recognizing that it really is a marathon. I don't think that any country yet really knows exactly what is the right strategy to focus on. There's got to be some kind of a compensation for the fact that some people aren't eating every day. So it seems like South Africa has taken some bold measures to try to deal with all of those things. And using anxiety, agency, action, collective action, and Ubuntu, most of all coming back to the South African ideals of Ubuntu. So thank you very, very much. That was an amazing presentation about how South Africa is doing. And it really sheds light on some of the media coverage of South Africa and gives us a really good picture of what's happening inside. We appreciate very much your presence and look forward to the question and answer session. Wonderful. So now we are going to move from South Africa, not too far, to Botswana. And it is my delight to introduce the Minister of Health for Botswana, Dr. Lemoga Kwape, and he joins us from Botswana. Welcome, Minister.
I'll preface my presentation with the chronology of events on our response to COVID-19. I think it's well known that the world all started to learn about COVID-19 sometime in January. And the reports were that it started off in China in December. And we keenly followed the WHO pronouncements because this was a breaking news, if I may call it that. But as we are following the WHO pronouncement, we really wanted to be proactive and started doing some very mundane screening at the port of entries. We're just doing temperature screening, checking for vitals like coughs, as indicated by the WHO. And we also immediately started a multi-sectoral national public response team at the national level and also at district level. In February, we worked on a plan of how we're going to approach this disease or this virus at the time. And we had a few stages that we thought will work. Maybe I should borrow on my South African counterpart, that we thought it was just going to be a quick sprint. We thought we could prepare and to be very, very strong on the prevention as we respond, and if need be, work on the recovery and mitigation. And that was in February. And lo and behold, in March, the WHO declared that COVID-19 was of public health concern, and we immediately acted by declaring the same in Botswana. Maybe a few days before that, we imposed mandatory quarantining at all ports of entry. So all returning residents were required to go on a mandatory quarantine. And following that, we established a presidential task force chaired by the president. Because we had a first case, we had the first extreme social distancing in April, and we had it for a few weeks until sometime in May. And we subsequently lifted the extreme social distancing and introduced zones. So you needed a permit to move between zones. To date, schools are open, and most of our businesses are also open. And we've also worked on decentralizing our testing. We used to test from one point, but now we are testing from about six points. In terms of our preparedness and response plan, it's pretty much anchored on thorough coordination, surveillance, and using rapid response team and case investigations. We've so far mobilized about 3,000 contact tracers. And in terms of our labs, we were supported by the WHO. And we are currently, as I indicated, testing from 6 sites with a testing capacity of about 4,000 tests per day. And all our commercial ports of entries are testing. And everybody coming into the country is tested. I must say here that we closed our borders save for goods, and those are the bulk of the people that we're testing in this country. So as I'll talk to later on, when I talk to the figures, I'll highlight where the numbers are coming from. In terms of risk communication, we've done a lot of community engagements through engaging with the community leadership, religious groups, social media, radio, so that we bring everybody on board, so that as we deal with the pandemic, we have buy-in from the community. In terms of the disease burden, to date we've tested over 53,000, and maybe I should indicate here that Botswana has a population of just a little bit over 2 million. And in terms of the positive cases, as indicated on the screen, we have just over 400. And our testing is about 0.1% positive. And we've only had 1 death. 71% of the people tested are either Botswana or residents of Botswana. The rest of them are people on transit, mainly truck drivers, who account for about 80% of the cases. And the tests at the borders account for 60% of all the tests that we do. So that tells you that being a landlocked country and getting supplies from other countries, the greatest risk is at the border. And we are a relatively young population in Botswana, so we've only had 1 death, and largely the cases are asymptomatic. But in terms of achievement and lessons, in as far as Botswana is concerned, we have a lot of political will. As I indicated earlier in my presentation, His Excellency the President chairs the task force. And in the task force, we have line ministries in the private sector, as well as other community leaders. At the same time, we have a coordination team that provides the technical support. Another achievement is that we've been able to detect the virus very early, and through testing and contact tracing. And I will repeat here that we strictly use the WHO accredited PCR platforms. And we have relatively low local transmission. I think to date, we've only had about just under 10 cases who were reported to have been transmitted locally. And we've been very lucky again in Botswana because the public engagement really helped. So the issue of buy-in really played a greater role in terms of our management of the disease burden. And masks are mandatory. So if you leave your house, you must have your mask on. Washing of hands with clean water and sanitizers is used all over. As I indicated, schools are open, and those were some of the things that we really zero in on, because young people are very difficult to manage, but we've had a very active team that provided for the facilities in schools. So all our schools are open, and so far we have not had any issues in as far as schools are concerned. We also had a lot of input from stakeholders, and they even went further by donating money and in kind to the fight against COVID-19. That said, we also have emerging challenges. As you are aware, and as the professor was saying, when he reported on the South African case, we are right adjacent to South Africa, and South Africa is the epicenter in the region. So that's where we have the greatest challenge because we get a lot of our supplies from South Africa. The other challenge is that we have, as indicated by everybody else, that limited access to supplies. That includes reagents, PPE, and equipment. In the country, we also have other health issues because people, especially during the period where we had extreme social distancing, we were getting very low in terms of our blood bank. Blood supplies were very low. So that presented a challenge because we couldn't do surgeries as planned. There are issues of addiction because at one point we stopped the sale of alcohol and tobacco. So there were psychosocial issues that came up, issues of gender-based violence. We also have issues, sporadic issues of crowding, especially in malls. In the past week, we had issues of fuel that was in short supply. So we had a lot of people crowding at filling stations, trying to get fuel. But all the same, with all those challenges, we also thought this adversity presented itself with a lot of opportunity, and we will carry this as we go forward to build a resilient healthcare system. We endeavor to strengthen the public healthcare system by preparing isolation sites, equipping facilities, and also providing the requisite human resource and the expansion of the testing so that it's not only done in 5 or 6 places, but it's done all over the country, especially at the ports of entries. We plan to, at full speed, be testing at about 10,000 tests per day. And unlike South Africa, we were only just initiating the private sector to be playing in the space of laboratory testing. And we're actively doing surveillance and active case finding. We are planning to do community testing so that we can investigate if there is some prevalence of the virus in the community, because we've been mainly focused at the ports of entries because that's where the risk was highest. And then the other thing that came out of this COVID-19 was the focus on research and development. Before COVID, we imported over 80% of our supplies. And now research and development is on a high. And the value chain in the agri space is really ramping up. We have companies that are manufacturing masks and sanitizers. So we thought with all the adversity, we benefited because with the adversity, we were able to really look into what we needed so that we can be less dependent on other countries. And also leveraging on ICT. I think we're having this meeting now. Ideally, this meeting would have to fly out and meet. But we think that we'll also be able to digitize our healthcare systems. And we're also looking at economic recovery so that we can sustain ourselves as a republic, as well as establishing the Botswana Public Health Institute, which we think will be critical in terms of planning for future disasters and epidemics. And also we continue to really acknowledge the support from our partners. But I must here emphasize that we need to really recognize our frontline workers, because they work day in and day out to serve the nation diligently. And I must borrow again from the professor, the Ubuntu. Here in Botswana, we say we offer a service with a human face. do unto others as you'd want them to do unto you. And we have also been very ambitious. We want to be a health hub, so that when other countries want to learn about how to manage COVID, they could come to Botswana. As I indicated, our numbers are relatively low, considering that we're right next to the epicenter, and that goes to the efforts that we've put in place to prevent and mitigate the virus from coming into our country. In a nutshell, that's how Botswana is dealing with the COVID-19, and I look forward to engaging with the participants as we proceed. I thank you very much.
Minister, thank you very, very much. That was a very inspiring session to see how really you've reported one death from COVID-19, and you're testing 4,000 people a day. Unbelievable. It sounds like if 80% of your cases are from truck drivers, so that's very much related to the fact that Botswana is a landlocked nation and that your supplies need to be coming from elsewhere, and you really don't have any choice but to allow truck drivers to come and go. This is a common situation. It's happened with many, many other disease entities. HIV, AIDS, other things like this have been spread by truck drivers in many cases. And it's not to make truck drivers look bad. It's just the reality of the life of the truck driver. And I think it's unbelievable to hear that the Botswanan president is actually chairing your task force. That is amazing. I don't know of any other country that's taking such a really proactive role from the very, very, very top. I think it's incredible that you've kept your schools open and that's worked really well, acknowledging the demographic of the nation being really young and keeping the kids and the young people learning and active seems to have worked really well. And the fact that you mentioned that this pandemic is going to be a turning point for the country and really instilling a lot of research and development, that's also really very inspiring. And your celebration of your frontline workers is something that I think the rest of the world is also doing. So that's great. We really do need to thank all of our essential workers, all our frontline workers, and the service with a human face inspired by Ubuntu. And the fact that you've acknowledged that you are really a leader in the region because you're sitting right next to the epicenter and managed to contain your cases is phenomenal. And I hope that other countries do come to you and do come to Botswana and learn from what you're doing. And I personally just want to say to you that I'm very excited to hear about everything that you're doing. I'm coming to your country. As long as everything's fine, I'll be there next year. So thank you so much. Thank you. Yes, wonderful. Well, so we move now from Botswana, from hearing from the Minister of Health in Botswana to having a regional overview now from the World Health Organization's African Regional Director, Dr. Matshidiso Moeti. Dr. Moeti, welcome. It is really an honor and a pleasure to have you here.
Okay, thank you very much. And first of all, thanks so much. I appreciate being part of this conversation. Thanks for the invitation. So we thought I'd give an overview of what's been happening in the region. So if we go directly to the next slide, please. So we have here a region that's done a couple of things in the last decade or so. First, introduced an integrated system for disease surveillance, just recognizing that because of the level of resources in the health systems, instead of having individual surveillance for different diseases, there was a strong attempt to have an integrated process for different diseases. So this IDSR, as we call it, and response has been in place, promoted by WHO, very much adopted by member states for quite a few years. And then secondly, this is a region that's very accustomed to outbreaks, disease outbreaks. So every year we support countries to respond to over 100 acute health events, as we call them, and most of them are disease outbreaks. Then We've done a recent evaluation after the Ebola outbreak in West Africa, in fact, when there was a heightened level of concern at the international level about the status of preparedness of most countries, including African countries, to respond to outbreaks. There's been a quite intense effort to carry out independent evaluations of the capacities of countries, and all countries virtually now have a plan on how to cover the gaps that they found. We carried out a readiness assessment on COVID-19 before any cases were reported in the region. And we had in place, as was said by Dr. Thierry, already preparedness for the Ebola outbreak that is just ending in North Kivu and Ituri provinces. In fact, we declared it finished in the DRC, the Democratic Republic of the Congo. So many countries had already instituted some of the preparedness measures. Certainly, point of entry screening was active virtually in all African countries where I traveled. People were getting screened. So there was a certain level of being prepared. And because the virus arrived in Africa some weeks after it had arrived, for example, in Europe, so in like March was when we started to see cases in the African region. There was some time to get prepared. There'd also been a lot of work done, partly through reforming WHO's emergency program after that painful experience of the Ebola outbreak in West Africa. And we were seeing that countries were overall, with support from WHO and other partners, able to detect outbreaks earlier and able to contain and control outbreaks more quickly, as you see on the right side of the slide. So there had been some progress despite the challenges that we face on health in Africa overall. The next slide, please. So this is just an overview of the situation and how it evolved, as you will see in the two graphs on the right. At the moment, we have in the region, so the African region is sub-Saharan Africa plus Algeria. So countries like Egypt, Morocco, Tunisia are not in our region. But on the continent now we have 625,000 cases and 13,700 people have died. And we show there the figure for WHO African region. And what we'd like to emphasize is that the evolution started off very gradually. We were seeing a relatively slow increase in cases. And then now we're seeing a very rapid increase. I have to say that a lot of it is driven by the data in South Africa. So we're not showing this graph here, but the shape of the graph is very different if we show South Africa on the region with South Africa included and with the South Africa data excluded. It's a much flatter curve, but it's a curve that's steadily progressing upwards in the region. We've seen increases as well in countries like Nigeria, in terms of scale, very different from South Africa, of course, Algeria, Ghana, Cote d'Ivoire, and now in Kenya as well. So what we're seeing, if I look at an overview of the region, which I'm not showing here as a graph, is that if we look at sub-regions, Southern Africa seems to be severely affected, and that's just the weight of the South African situation. Then West Africa is where we've seen a number of countries with the next highest level of cumulative cases. And then we are seeing in East Africa and in Central Africa, relatively fewer cases, though we have countries like Cameroon, where there is generalized community spread. So on the right at the top is the graph, because we tried to have fewer slides, of the world. And the Africa is near the bottom. You can hardly see it. No, Africa is at the top. It's very, very tiny compared to the global situation. And the Americas are dominating the situation globally at the moment. And you also see the other regions, Eastern Mediterranean, Southeast Asia. So in relative terms, in terms of numbers, it looks like a very small number of cases. We've had countries like Mauritius, Seychelles, Zambia, Botswana, Namibia as well, which have managed to contain the situation. In Namibia and Botswana, we've seen in the last couple of weeks an uptick in cases, and we think that's mainly related to cross-border cases coming in from the South African situation, which we believe they will be able to contain with what they put forward as their strategies. Next slide, please. As you recall, there was a lot of worrying and fretting globally about what was going to happen in Africa with its health systems that have gaps, where the resources are not so great, the health infrastructure is not as abundant, the human resources, etc. There was a lot of fretting at the global level, expecting a catastrophe to overwhelm the African continent. That was in all the discussions about the pandemic in Africa. What did make a huge difference is that African leaders really took strong action early on in the pandemic. So we've seen at the level of the African Union, I've worked with the African Union for over many years, and what has happened over this pandemic has been unprecedented in terms of not only political mobilization and expression of commitment, but of decision-making and action, which with strong continental solidarity, but very much implemented at the national level. And it's in quite a few countries that heads of state put in place these multilateral task forces at a senior level. And I believe the dynamic, the consultation, and I think that President Cyril Ramaphosa has played a very positive role as the current chair of the African Union in creating a certain dynamic which has translated into reaching out to the African private sector, reaching out to the African diaspora, and really getting into action. In my view, that's quite unprecedented. But what the countries did is institute the lockdowns. And it's already been said, it's been expressed that these have come at a huge cost for households and for national economies. And we are at a stage now where we believe that they did buy some time. They did in quite a few of the countries flatten the curves, but the costs are felt to be such that most countries are now easing the lockdowns. So we show here the numbers of those countries that did a national lockdown. Some were partial, and some were, in some senses, in some cases, restricting travel out of the capital city where the virus first entered internationally. So what is going on now, and I think what's being discussed, these presentations illustrate very much this balancing of the impact on controlling the pandemic further and just accepting that the cost is too high in terms of livelihoods and economies have to be opened up. There was also a lot of work to scale up the capacities for the public health interventions for testing, contact tracing, and isolation of cases. We've seen a number of countries manage to decentralize their testing capacities, even the incident management centers, so that they are becoming more and more established at the regional and sometimes even district level. We are a bit concerned that it's not the case in every country. And now that the lockdowns are being opened up, we are anticipating seeing increases in number of cases and are hoping that the scaling up is really sufficient to be able to detect cases. So we're in a sense accepting that there will be continued spread of the virus. What we would like is for the capacities to be there to find the cases quickly, isolate them and their contacts, and to limit the spread. It's already been said, so I won't repeat the huge challenges countries have faced in scaling up even testing because of the distortion of the global market in these commodities. It's been very, even middle-income countries that have their own money, I think Slim said it very clearly, have just struggled to be able to procure some of these commodities. WHO is working with partners. We have a procurement platform, a consortium at the global level with the UN. It's been extremely difficult. It's been one of the, I guess, one of the challenges of having a global pandemic, truly global, and frankly, sometimes one of the failures of global solidarity. So some of the countries that have production capacity for these items have prohibited exportation, And that's one of the challenges that is being faced with the Gene Expert platform, which is present in terms of equipment in a decentralized fashion in many countries, unlike the PCR platform. Commodity engagement is ongoing. Again, this is one of the areas where a lot of work was done, where a lot more work is required for several reasons. There's a lot of stigma attached to COVID-19, which has surprised me as somebody who's worked a lot in HIV, sexually transmitted infection. So I'm always striving to understand, is it fear? What is it? You know, you just breathe and you are infected with this virus. So we're needing to understand what is the source of the stigma? What is it that people are understanding, and what needs to be done in communication, which I believe needs to be very much more grounded at the community and the grassroots level through multiple channels, through informal associations that people have, through trusted intermediaries and interlocutors, and also very much through a good collaboration with the press. And there's been a very impressive body of work done in terms of research and development, in engaging in research. We are seeing African countries sign on to some of the clinical trials that are going on for therapeutics. At the moment, it's only South Africa that's involved in a vaccine trial, and we are encouraging very much our member states to get on board with this, because this can only be to the benefit of African people, to try out these therapeutics and the vaccine in African populations, to understand how it then behaves in terms of efficacy and unwanted effects. Next slide, please. As I said, and it's been said, that the socioeconomic impacts have been considerable. The impact on livelihoods was immediate as soon as the lockdowns were introduced, because of the huge proportion of people who work in the informal sector. So people who work in households as house help were immediately, as soon as they couldn't get to work, dismissed from work in many countries and just stopped earning a living. People working in markets and so on. It's been extremely difficult. And what we are hoping is that the price paid will be compensated by the time bought in scaling up the public health measures, which will then be another way of working on controlling the virus going into the future. Several other sectors are affected. We're concerned about agriculture, because the agricultural inputs have not been able to be moved around at the right time for the seasons in many countries. So again, the impacts are going to be continuing economically. Just to highlight the disproportionate impacts on women, although they don't constitute a majority of the cases, most of the work of the health workforce is women. And they're also the primary carers at home. They're involved in some of the businesses which suffered most as a result of the lockdowns. And we've seen in countries an uptick in gender-based violence. There's also been an impact on access to essential health services in many areas, immunization, shortages of antiretrovirals in some countries. Access to family planning services has dropped drastically in a number of, in one country in Zimbabwe, it decreased by 90% over a couple of months. So there's a lot of work going on to support countries, encourage them, and to give them ideas about how to continue, sustain essential services while minimizing the risk of transmission of COVID-19. Next slide, please. So what we are hoping will happen out of this crisis, in addition to the myriad lessons that we are learning about how to do business, including public health business remotely, how to carry out training, how to be connected, sharing ideas without having to travel. One of the lessons that we are hoping will emerge, something that's been repeated as we have seen the SARS, the H1N1, and now this pandemic, is really about investing in health systems, in resilient health systems, integrating the needs for preparedness to face outbreaks, health security, and also investing in equity as far as health is concerned. Because we are seeing how people who are vulnerable, who have to pay and cannot afford to pay for healthcare in some countries, are disproportionately affected by the virus, even if in many countries it entered into the upper echelons of society, people who were traveling to and from Europe, because most of the cases in African countries were imported from Europe. I already talked about the role of technology. I think it offers huge possibilities which are being used now, the use of geographic information systems for surveillance, for monitoring population movements, which is being done in a number of countries to see if the physical distancing is being applied, is really working or not, for training. And I think it'll work not only for health, but also in education, how to expand access to learning for children who cannot be in a school physically, if we can find ways to leverage technology in affordable ways. And then, of course, the connection and partnerships that have arisen out of the work on COVID-19, we are very much hoping will be sustained into the future, including the platforms that have been set up in countries for multi-sectoral coordination, because they are relevant not only for this pandemic, they're relevant for virtually all other health problems. And this is an aspect of health development which is challenged in the region. The role of the private sector has also been quite prominent. They've organized themselves and they've provided partnership to governments, even as they are seeking to make money from their investments in health. And this is something I think that we can pursue in a more intensive way going into the future for leveraging their resources for health as well. Next slide. So if I can just leave some messages here, is to reiterate, health is the business of the whole of society, every sector, and very much people, the population. Then we simply have to accept, and I'm echoing somewhat what was said, particularly by Slim in the South African situation, that this virus is going to be around for some time, and we need to find ways of balancing, addressing it with dealing with it in ways that then might have even higher costs in terms of economic impact, especially on the most vulnerable people. We need to reinforce very strongly what people have to do themselves then. The wearing of masks and the hand hygiene, where in many settings people need help with this, access to water and soap, the physical distancing. We actually think that governments need to be looking at who can afford to buy a mask and who cannot, because there are people who simply don't have the money to keep their supply of masks in the household going. And then finally, investing in the public health systems in the region. It requires financing because it's a good investment. It requires persistence, it requires innovation, and just to end by impact mitigation on people. We believe strongly that people who are struggling to put food on the table are not going to be listening when you talk about please keep your mask on, please don't crowd into the taxi, and etc. Please keep your distance from people. So one of the areas that needs additional investments at the level of governments and of partners and international solidarity is socioeconomic impact mitigation, finding those people whose situation is really so acutely difficult that they can hardly even play their own role in preventing the transmission of COVID-19, which is a very important thing for everybody to be engaged in. So my last words is, we need to find smarter ways of engaging people so that they internalize the message, so that they indicate where their limits are, and we then have to find ways of covering those limits. And just to say, those pictures on the right, the bottom picture is my future women leaders in WHO. These are senior women staff when we're carrying out a women leadership program. And to say, not to be naughty, somebody sent me a slide of countries that at the global level, countries that have done well and who is leading them, and countries that are struggling and who is leading them. And believe me, those that were doing well were all led by women. And thank you very much for having invited me. Not that that's a bad mark for our male leaders, because there's some fabulous male leadership around. Thank you. That's the end of my presentation.
Dr. Moeti, Thank you very, very much. And for ending on that note of strong female leaders, we are very pleased that you, as a strong female leader, were able to present and round up the presentation from all the other presenters. You made some really, really important points about which parts of the continent are struggling, and then pointed out that despite the reality in the African continent, the Americas actually have the worst situation. And you pointed out that there are many nations within the African continent that have done excellent containment of this virus. You said that there had been a lot of worrying and fretting about what was going to happen in the African continent, and yet most of this actually hasn't been borne out. You talked about the strong national and continental leadership, which has led to some new collaborations within nations, between nations, and new partnerships. And you hinted at the idea that therefore this pandemic could actually lead to some kind of catalytic change that could really lead the continent forward. You mentioned one thing which certainly is happening in many nations, and none of the other speakers did talk about, which is the stigma of COVID-19. And it is something that's happening around the world. It's not happening in this part of the world where I live, in Canada, but it's happening in a large number of countries where there is some kind of a stigma. And it does seem a little bit curious because, as you said, we don't get COVID-19 through anything like HIV. It's not sexually transmitted. So it's one of those things which we as societies will have to grapple with, this question of stigma. One of the other things that you mentioned was, again, something that could be very catalytic and bring forward really good change, is the research and development which is happening within African countries to solve African countries' problems. And in the end, that's really the only solution, made in Africa solutions for issues that are happening in Africa. You made a really, really good point about the socioeconomic impacts. And I really want to emphasize that because we didn't talk enough about that in the other presentations. You talked about the impact on education, on livelihoods, access to services, on the economy, on the health system itself, and how many, many other essential parts of the healthcare system have simply not been able to do their work, from family planning to immunization to surgeries and other things. We've been neglecting other things which we really need to do. And then you talked about how within most African nations, the experiences of other pandemics have really taught most nations how to handle this. And the world's experience with SARS, H1N1, West Nile virus has been preparatory for this particular phase. You talked about the way that technology is really making a difference here, but you didn't talk about the potential human rights impacts of that, because certainly we're seeing both sides of that coin. We're seeing that technology is helping us to do the surveillance, and it's also helping us to surveil people in ways that could be nefarious. So I think that's something that's worth talking about. You raised the point that many of us in public health talk about all the time, where we say there's health in all policies, when you said that the whole of society has to get involved. But now what I would like to do with thanking you, Dr. Moeti, and the health minister from Botswana, Dr. Slim from South Africa, and Dr. Thierry Nyanti from Rwanda. I would like to ask you all to open your videos, and I'm going to start with our first question. And I've just got to request all of you a little request. If we could stay a little bit longer, because we've had such stimulating discussions from all four of you, that we would like to have a little bit of time for some question and answer. So I have a question which is kind of a rolled up question from many of the audience members who are here. And it really stems from one of the last things that Dr. Moeti said, is that people who are struggling to put food on the table are not really going to listen to all of these orders for distancing. And one of the things that we didn't talk about yet in this session is that COVID-19 measures which have occurred in the places where COVID-19 has been more severe, like the Americas, have included lockdown and quarantine. And governments have been able to give people finances. In Canada, we have things like the CERB, which is a financial benefit, $2,000 a month that goes to workers. So in many African countries where these kinds of measures are not in place, although we did hear that in Rwanda, everything's free, including quarantining. So I'm assuming that means that everybody gets paid to stay at home. I wanted to ask all of you if you could comment on this balance between trying to take very strict and strong measures against COVID-19 while trying to keep food on the table and trying to balance out all of the social determinants of health, including income, social status, and women's rights. We've heard from a few of you that women's rights have really suffered during COVID-19, and this is not a minor issue. So if we can just talk about this balance between perhaps what we might be calling a copycat measure of locking down African health systems when the demographic is under the age of 15, and the vast majority of deaths to COVID-19 are much older demographic. So how are you doing this balance? Dr. Saleem talked about this damned if you do and damned if you don't policy, but how can we move forward, and how can we take up the challenge that Dr. Moeti made of engaging differently and using this pandemic as a catalyst for change that's really going to move African health systems and African health status forward? So I'd like to begin with Rwanda, because we began with Rwanda. So Dr. Thierry, s'il vous plaît, allez-y.
Thank you so much. Thank you for the questions. I think they are really pertinent questions and really challenging in terms of how to address them. And indeed, same for Rwanda, we have experienced such challenges in terms of when we instituted the lockdown. How do you assure that people keep on with their livelihoods? And again, while in my presentation I highlighted the need for a multi-sectoral collaboration, because these are issues that can't be resolved by the health sector only, but these are issues that are supposed to be resolved by different sectors, different government institutions, and of course, the leadership has to be very firm in terms of addressing these issues. So as I said earlier on, one, how do you make sure that you install that trust in the population and make sure that people really do understand that the benefits outweigh the risk? And I think if that communication is well done, then I think people can buy in and actually can contribute to some of these measures. So I think that's my contribution to that. I think it's all it's a holistic approach, and of course, with a holistic approach comes different solutions from different people. So I would say that would be my contribution based on our experience here in Rwanda.
Merci beaucoup. Yes, thank you. It is that balancing act. And Dr. Saleem from South Africa, please go ahead. Dr. Saleem
has had to leave. He sent a message on the chat saying he apologized and said goodbye. He has a meeting.
Oh, okay. Thank you so much. Thank you so much. Okay, so then we're going to move to the Honorable Minister from Botswana. Please go ahead. Oh, Minister, you're muted. If we can ask you just to unmute your microphone, please.
Thank you very much. I think that is a very difficult question, but especially when you're dealing with a pandemic. But we've learned through this that engagement with the community, it's of critical importance. And when you engage and they understand what you're dealing with, even when you bring interventions which may be unpalatable, they tend to understand why. There's an adage or an analogy that we use here, that if we protect our means of production and let everybody die, what are we protecting them for? So when people begin to understand that, then they tend to be proactive in their actions. But in terms of what the government has done, especially for businesses and workers, is to have a wage subsidy, and so the businesses can continue and the workers can support their families. And for those who are not working, we have a food basket that we're giving out to the public. I think all in all, considering the population of Botswana, almost a quarter of the population was provided with that food supply. And then it's also reassuring them that if we really work together, we can fight this. And I always say that when you look back 100 years ago, when we had the 1918 flu pandemic, it was followed by the Roaring '20s. So that kind of a messaging really helps to get buy-in from the community so that they know that it's a cause worth fighting for. So when you're all on the same page, it's much easier for you to find ways, difficult as it is, that you try to deal with the disease, and at the same time, and not letting people to their demise. But all in all, in Botswana, difficult as it is, people have been very receptive. The classic one is the masks. Normally if you ask somebody why they're not wearing a mask, before they would say, it's none of your business. But today they just literally reach for their mask and start wearing it. And that goes to show that the engagement with the public, getting the buy-in, really, it plays a major role. I must say, if we didn't do that, then we would have a much bigger challenge. But and they believe in the hope that we shall overcome. I think it really helps for people to have hope. When we hear about the trials on vaccines, this is communicated to the people. So if they know that there's work in progress, then they believe that there's light at the end of the tunnel. I think that is really helpful. It's a soft side, but of course, the issue of providing them with supplies, giving them wage subsidies, really keeps them going with the limited resource.
Thank you so much, Minister. That message of hope is really, really valuable. And so now I'm going to move to our WHO African Regional Director, Dr. Moeti. Oh, and please unmute yourself, Doctor.
Okay, sorry, I was trying to read some of what's being said in some of the chat.
Yes.
And see if there's to respond to it. So somebody says, okay, the presidents may not be doing enough due to politics. I don't want to delve into that, but just to acknowledge that the politics of it can sometimes be very difficult. And again, it's dealing with the juggling. And in some cases, you're damned if you do. So whatever happens, we've got a couple of African countries, as you might have heard, where the WHO representatives were kicked out by the governments because the politics got so intense. The debate in the parliament, the criticisms of the government by members of the opposition can then be, okay, it's because you gave the wrong numbers about our country and it's your fault, WHO, and bye-bye to the rep. So that side of things also needs very careful thinking about. And what is really needed is, if we talk about global solidarity, we really need solidarity at the political level in countries, across political divides, for this common objective of helping people, especially helping the government, because the government's actions pay for everybody, whether we are in the opposition or not. If you give the government space, the president's the space to make difficult decisions, it pays for you as well as your followers. So if one has anything to say, it's to say we need global solidarity. We talk about that a lot. We need political solidarity at the level of countries. There's something that endangers everybody. And as I said, very much the people as well. So I'd just like to make that my last comment about solidarity of all types.
Thank you so much, Dr. Moeti. Politics certainly have featured large in this pandemic all over the African continent as well as the world. And we've seen that particular ideological leanings have been either science friendly or science hostile. We've seen quite a variety of ways in which politics can be engaged in COVID-19. And certainly your message of global solidarity is one that the world needs to hear today. Thank you so much. Wonderful. So I believe we have now asked everybody our question. We've gone a little bit over time. I would like to thank from the bottom of my heart all of our esteemed speakers. Hearing from the leadership in Rwanda, in Botswana, in South Africa, and Africa at large has been incredible. It's the kind of thing that the media rarely gives us a chance to hear, the capable and strong leadership that really does exist, and the fact that African countries have so much to teach the rest of the world. So it has been my pleasure to moderate this, this Afrocentric session on African health systems and COVID-19. And I'd like to thank you very much. And I'd like to give the last word to my friend and a student at UBC, Professor Hinda Rutan, who is here finishing his PhD at UBC. Please go ahead, Professor Rutan.
So just again to thank you everyone. My name is Hinda Rutan. As you said, I'm a professor at the University of Rwanda, as well a PhD candidate at the School of Population and Public Health. And again, I'd like to take this opportunity to thank everyone, speakers from everywhere, the attendees as well. Despite going over time, they were still participating and still there. Thank you very much. I would like as well to remind you that this is a webinar series. The next session will take place at the end of this month, and it will be on food system and nutrition. Please, we ask you to join again. Thank you very much.